By the people, for the people, the gathering to get healthcare now. Chapter 15. Contracting with the insurance companies. Most major insurance companies contract directly with individual practices to provide medical services for their policyholders. They have preferred provider plans or HMO plans and very few open access indemnity plans. They expect to spend 80 to 85% of their premiums on hospital and medical services, 10% on overhead, and 5 to 10% for their shareholders or for dividends for their policyholders if they are a mutual company. Many times they fail to reach their budget goal. But in the last 5 years, under the Medicare and Medicaid plans, many plans have been able to match the targeted percentages in each category. Under the new law, they will have to reduce marketing and sales costs and profits to reach their 80 to 85% medical loss ratios. Reducing or holding the line on payments to the healthcare providers will not give them more profits, but will lower the prices to the government and to the patients. Contracting with individual practices is the safe way for insurance companies to limit the fees they will pay to physicians and to retain any of the surpluses they might accumulate. The companies fix fees by using Medicare-approved rates as a basis, paying some percentages above or below the Medicare rate. The range is from 80% of Medicare for diagnostic and surgical specialties to as much as 130% of Medicare for primary care. The large employer plans and the Medicare and Medicaid plans cannot exclude individual patient members, but can limit coverage through higher deductibles and coinsurance. If these deductibles and coinsurance amounts are high enough, they can transfer bad debt to the practices too. However, insurance companies usually manage financial risk by terminating physicians who have high-risk patients and who are not taking part in the utilization management program of the company. Having an individual contract between an insurance company and a medical practice is not physician-friendly. In fact, many physicians have overcome this obstacle for years by forming associations to do the contracting. This practice has worked to the advantage of the physicians in some cases, but not in others. When the association is very large and connected to a hospital system or inspired by a medical association, it looks very much like a union to the insurance companies and to the Federal Trade Commission. Since big insurance influences government and the union-looking associations have had many days in court for de facto price fixing, these associations have usually lost in court and been told that they must be at risk with the insurance company. Therefore, fees are not fixed but vary as utilization rises and falls. Usually, large associations do not operate well as teams. To work well, they would have to be broken into small groups that would exclude many of the member physicians from some plans. In large group mode, the providers have their fees reduced, withholds retained, and administrative costs increased. What works is a physician team serving a specific patient population that is no greater than the team can manage in 1 or 2 hospitals. Some IPAs have decided that this is the kind of organization they want and have made contracts with insurance companies that are fair to both parties. There is a temptation for physician IPAs to want to be a capital stock insurance company and have it all. This has been tried by some large group medical practices already, but seldom, if ever, by an IPA. The capital requirements of operating even a modest HMO plan are astronomical. As an example, the IPA incorporating 40 PCPs, each of them having 250 Medicare patients, would have 10,000 Medicare patients. The average premium per year for that is $120 million. The reserve is $30 million. The development cost is $2 million, and the minimum capital and surplus is $2 million. This means that a group needs at least $34 million to get into the game in a meaningful way. Missing the targeted budget by more than 5% may impair the IPA and lead to asking shareholders for a bailout or closing its doors. A better strategy is for the well-organized medical team to contract to share the profits with the insurance company. The insurance company should be well capitalized and willing to manage the IPA's financial risk. Such an insurance company needs the IPA to help make profits for their shareholders. The costs mentioned are not peculiar to the health insurance business. They are typical of other types of casualty insurance. The target margins for marketing, sales, administration, and profits are from 25 to 40% of the premiums. The contract must call for full disclosure of the income and expenses in every detail at every level. Individual physicians rarely get to see the detail. Thus, most associations of physicians, large or small, don't get to look at the 15 to 20% that is taken from the top of the premiums and called administration and marketing expenses. Much misinformation surrounds the enrollment of patients into Medicare Advantage plans. Despite benefits for enrollment in these plans being greater than those in Medicare or supplemental insurance alone, the Center for Medicare and Medicaid Services restricts the time for enrollment in MAPS. CMS also scares both physicians and agents from telling eligible patients about alternative plans. The open enrollment period is currently 3 months less than allowed by past rules. Exceptions: individuals just becoming eligible for Medicare, those enrolling in CMS 5-rated star plans, those in special needs programs, and those who are also eligible for Medicaid. 90% of the eligible population has only the open enrollment period during which to change to a Medicare Advantage plan. The private insurance industry that sells prescription drug plans and Medicare supplements plans is protected through non-exposure. Most MAPs are HMOs that have the freedom to choose any doctor or hospital that accepts Medicare within their restricted HMO contracted networks.